today in this hearing of the all-party group on coronavirus, we're going to hear evidence of the effect of those living with long COVID who are in frontline positions and at work, the effect that it's having on them, but then also here in our second panel from various unions and clinicians who can shed some light on what needs to happen next. So in this first 45 minutes, I'm delighted to have with us, for the first time, we have Sophie Evans. Sophie is a 28-year-old NHS midwife and A&E nurse. She contracted COVID-19 at work while caring for COVID-positive patients, and many may recognise her from her stunning interviews that she's been giving across the BBC. So it's wonderful to have you with us, Sophie. Thank you so much for joining us. Geraint Jones has spoken to this APPG before, so welcome back, Geraint. Thank you so much for coming back. He's an advanced pharmacist specialising in HIV and home care, and Geraint continues to live with long COVID. Thank you so much again for sparing the time. Also with us for the first time is Susan Coomber. Susan is a chemistry teacher and contracted COVID-19 a year ago. She now continues to live with long COVID. And finally, Professor Trisha Greenhalgh. Trish is a professor of primary care health sciences at the University of Oxford, a constituent of mine, and very proud that I am her MP. And since the start of the pandemic, Trish has written extensively about long COVID and co-authored the recent WHO policy brief on long COVID. So you're especially welcome, Trish. Can I just double check, you are not living with long COVID, however, is that correct?
That's absolutely right. Yeah, no, I've not had COVID. I've just had my vaccine, so I've escaped it. Yeah.
Oh, well, good. We're delighted to hear it. So I'll kick off, particularly focusing first on Sophie and then on Sue. If you could just let us know, what's your story so far? When did you contract COVID, and how are you feeling now?
Hi, everyone. Yes, so I contracted COVID. I tested positive on the 12th of April last year. My first symptom was on the 1st of April, and my symptom was literally a headache. That was it. I just thought I was tired. I was working a lot of night shifts. It was incredibly busy, as you can imagine. So I just took some paracetamol, thought it would be okay, woke up the next day. I couldn't tolerate any sort of light, so couldn't look at my phone, couldn't look at the sunlight. And I thought, okay, obviously not just a headache then. I somehow made it to work the next day, I don't know how. And basically about 8 hours into my shift, my temperature had gone up slightly to 37.8, and then I thought, maybe I'm probably showing signs of the virus, but I actually still thought, it could have been something else. I'd just come back from holiday, so I thought that maybe I had the onset of a tropical disease because I'd been somewhere rather tropical. And basically I deteriorated rapidly in that time. The first 12 weeks, I was hospitalized twice. I could barely move. I couldn't look at any sort of light for basically the entire summer. I was vomiting. I couldn't move my head at all. It felt like someone had hit me around the head with a shovel. I was in extreme amounts of pain. And unfortunately, we are now 11 months on and not much has changed other than, yes, I can tolerate the light now. That's a lot better. I can tolerate noise, but I still feel sick every day. I've hardly got an appetite. My headache is exactly the same, pretty much like it was on the 1st of April. I've had no relief at all. I've got loud tinnitus. I've got a sore throat every single morning. I feel like I'm constantly coming down with something, that initial feeling. So overall, it seems that it's sort of destroyed my life at the moment, and I hope that it's temporary, but I'm not sure if it will be.
Thank you so much. And have you had, in terms of your return to work, and how much are you able to do? How much support have you had? Have you had financial support that you need?
I'm not back at work, I'm still off sick. So the major issue I actually have now is that my temperatures are over 37.8, mainly 38 and above every single day. So technically I am sort of showing coronavirus every single day, or showing the signs of. So even if I was fit and well and only just showing the temperatures, I wouldn't be able to go back to work anyway, because I now fall into that category of constantly being symptomatic, even though I'm consistently testing negative. So technically I should always be self-isolating because I'm constantly showing signs of the virus. So that's sort of one issue of many. Financially, I am on the sort of coronavirus code, so to speak. So, and rightly so, because I am exhibiting signs of the virus every single day. But that was a struggle to sort of be put onto that code, or to be maintained in that code. My manager, my GP, my immediate colleagues have been absolutely incredible. I couldn't have asked for a better support network at all. But unfortunately, the sort of the HR side and the occupational health side has really let me down, actually. And unfortunately, the HR side was sort of misinforming sort of my manager, in terms of saying that I should be actually testing positive to be able to be actually off with the coronavirus coding on my sort of roster, so to speak, which is incorrect. But that's just sort of one of many issues that I've had. So whilst you're desperately unwell, you're having to sort of fight against a system that's not set up to help people like myself. So it's been a challenge.
Thank you for sharing that. And how about you, Sue? Tell us your story and how are you feeling now?
Well, I got COVID probably about a year ago. I had anosmia, fatigue, wasn't feeling too bright, but my temperature was really low. So it was about 35 and a half. And this went on for a while. And I phoned my GP and he said, well, because of the low temperature, because you've not had contact with people returning from Italy, it's unlikely you've got COVID, you've got a cold. And as time progressed, we went into remote working. So I was fine. I was working at home, didn't have to do a great deal, but my breathing was getting rapidly worse. And I kept in touch with my GP. She was very good. She didn't know a lot about it, so I was reading, telling her what I'd found out. And she was concerned that my respiration rate was too high. So they sent out a paramedic. I got ambulanced into hospital because I wasn't allowed to drive in. Got kept in. I had pulmonary embolism, put on blood thinners. I mean, my GP was amazing to diagnose that over the phone. So I was doing all right. I mean, I'd taken this graded exercise therapy pathway, which we now know is a huge no-no. And I was out with the dogs. And I got up to about 6 kilometers. And I was quite keen to try and exercise because I've had a knee replacement a year last November. So I needed to sort of get my strength up with that. And I was on the phone to my manager, looking forward to returning to work on Monday. Brilliant. Following morning, I couldn't get out of bed. And since then, it's just up, down, up, down. And on a good day, I'm about 70% of what I used to be. On a bad day, well, it's very bad. I get worn out wandering around the house, but I'm better off than many. I feel very much a walking wounded. But I find anything like lifting, where I've got to exert myself, above just sort of maintaining my body, triggers fatigue. So I don't really know how I got it, because outside of school, I've had enough of people. It's a very people-intensive workspace, and I live on my own. I do my weekly shop at Waitrose about 7, 8 o'clock at night, so there's not many people in the shop. And I just don't know where I got it from. I find it quite frustrating. I don't live with the severity of the symptoms that others have. But it's very frustrating for me not to be able to get on with my normal life, which is gardening, decorating, laying patios, you know, being very outdoorsy.
Yeah.
And it's really quite frustrating. And my concentration is not that good.
Oh, forgive me. I didn't mean to interrupt you. How has it affected your ability to, have you been able to go back at all? How has been the response of HR and?
Right, well, I started back on a phased return on the 18th of January, when I was feeling a bit more reasonable. But over half term, I took a massive dip. And they decided last week that I was, a week before last now, that I was unfit for work in the physical environment. I did go in for a day, got sent home at lunch. It was just the sheer physicality of walking around a school, going up and down the stairs. That was the trigger. Occupational health have been marvellous, actually. Very understanding, very clued up. I had an OH appointment this morning, so it's a bit of a full-on day for me. But they've recommended another return to work on phased with accommodation for 6 weeks, and I've yet to hear the school's response from that. My GP has been great. You know, she's done her best to keep up with what's going on, but she's obviously got lots of other things to think about. Always there if I need an appointment. I'm very supportive in the limited way that it can be supported. HR, on the other hand, at school, bless her socks, love her to bits, but she still thinks that the doctor can cure me, that the doctor can give me a medication that's going to work. And okay, I now have hypertension, which I've never had before, and I have medication for that. But what do you give people who possibly have a mitochondrial disorder? You know, there is nothing. So it's frustrating, but as I said before, I'm a lot better off than many.
Thank you so much, Sue, for sharing that. And just quickly, Geraint, how are you doing? How have you been since we last saw you?
Hiya, sorry. Yeah, so I'm still off work at the moment, still experiencing sort of fluctuating symptoms still. So like Sue, cough, palpitations, my abdominal pain and diarrhea has kind of flared up again over the past couple of weeks or so. It's just that kind of this relapsing, remitting type pattern that everyone seems to be discussing, but we don't really know when it's going to end or how it's going to end, to be honest. So yeah, it's kind of pretty much the same pattern really, with the same symptoms, just a few months since we last spoke. So yeah, nothing's really changed, to be honest.
Well, I'm sorry to hear that, genuinely. Well, thank you for joining us again. So I'll now pass to Caroline Lucas.
Thank you very much, Chair. I wanted to pick up actually on that whole issue that you have been describing, the relapsing, remitting nature of the illness. You've all touched on it. I don't know if there's more that you wanted to say about that. Ultimately, I wanted to ask Professor Greenhow about the clinical perspective on this remitting nature of the disease. But did Sophie or Sue or Geraint want to say anything more about, I mean, does it literally change from day to day? Can you get a sense in advance that it's going to change? Or is it just utterly, Sue, maybe?
Yeah, I get very fizzy muscles. You know, I know if I'm doing something and this fizziness kicks in, that I've gone too far, or I'm on the brink of, you know, pushing myself just too far, and I'm going to suffer the following day. And it's quite useful to know when I have to rest.
And if you take action quick enough, can you avert the relapse that will be on its way?
The depth of the relapse is the thing.
Right.
You know, if you catch it in time,
yeah,
and make sure that you know, park yourself up on the sofa with an audiobook,
yeah,
then it tends not to go as deep.
Okay.
As if you thought, oh, I feel brilliant today, let's go and do 2 miles.
Yeah.
Well, it's peanuts, but you know, and you find yourself a mile out from home.
Yeah.
And it takes you 3 times as long to walk home because you have to keep stopping.
Yeah.
And then it really kicks in.
Yeah. And Sophie, is that your experience as well? That kind of, do you get any warning?
No, so mine's a little bit different because thankfully I don't have the fatigue side of it. For me, it's just the severe pain in my head. So when I wake up in the morning, there is sort of no early identification as to what sort of day I'm going to have, because most of the time it's pretty much the same. I'm just in extreme amounts of pain, mainly with my neck and my head. And then on top of the being symptomatic of the high temperatures as well. So when it is sort of cold now, but when it was snowing, for example, I could have easily been out in a strappy top and some leggings because I'm so hot all of the time. And pre-COVID, I was that person that would be, you know, hat, scarf, gloves, thick coat on, going to bed with a hot water bottle. So if you sort of look at me pre-COVID and how I am now, it's just totally different. So yeah, for me, I don't really have that relapse remitting sort of issue, because for me, not much has changed in the 11 months. It's an odd one.
Okay, thanks. And Geraint?
Yeah, like I kind of touched on previously, really, is just like my presenting sort of illness was abdominal pain and diarrhea, really. But again, out of nowhere, then I had this chest problem, and then it was my heart, and then kind of that subsided a little bit. Then my stomach flared up, and then the palpitations were back. So, like we said, it's kind of just this up and down constantly, and knowing about what symptom you're going to experience next. I've had a couple of weeks.
Back to work at all in between times, or not?
No, to be honest, I don't think I'd even mentally or physically be able to cope at the moment, which kind of does leave me in a bit of a position where will I be able to do the job that I previously was doing? And this could be the same for a lot of other people. Like, are we going to be having a massive de-skilling of a workforce, essentially, which is quite, well, problematic for the health service, really. But in terms of personally, yeah, it's just, again, just at this constant up and down, living in limbo, just day to day and waiting for the next day and hoping that it's going to be a good symptom day rather than a bad one. But it's just, yeah.
I'm so sorry. Professor Greenhow, could you tell us a little bit about your perspective on the clinical side of this relapse and remitting?
Yeah, sure. By the way, do call me Trish. First of all, I'm not currently in clinical practice. I'm full-time academic, so I'm not seeing patients with long COVID in the capacity as a doctor. The 3 examples we've had are really brilliantly illustrating the diversity of long COVID and how it manifests. But the specific question you asked me is what this sort of relapsing, remitting. Yes, it does relapse and remit. We interviewed 114 people for our research. They all had long COVID. They had it in different ways. And I guess about half of them were describing the sort of ups and downs. But I would also like to point out, in most cases, this does gradually get better. It doesn't get better overnight, otherwise it wouldn't be long COVID. But in addition to the sort of ups and downs, possibly triggered by overdoing it in inverted commas one day, you're then very tired the next day or whatever. That's the sort of short-term ups and downs. But over the long term, many people with long COVID are slowly getting better. We have no idea what's going to happen over the next year or 2 years because this is a new disease. But it is certainly not the case that there's no hope for people like Geraint, for example. You know, is he ever going to get back to work? We simply don't know that. And as you know, there is research going on. But so I hope people will eventually get back to work. But we can see just how pervasive the impact is on people and how difficult it is for them to go back into the workplace when they have these multi-system symptoms.
Thank you. And just finally, did you also in your studies come across people perhaps whose experience of long COVID was less severe than what we've been hearing about today, where there has been this constant trying to go back to work and then being knocked back, and the problems associated with that?
Yeah, but I mean, I would say people are getting back to work. Some people are getting back to work, and I would say the thing that it helps them more than anything else is flexibility in what used to be known as phased return to work. I guess it still is, but 6 years ago I had breast cancer, I had some time off for chemotherapy, all that kind of thing, and then I had a phased return, and occupational health were fantastic, 4 hours, and then go home and crash out because you're so exhausted after, because you've had a severe illness. And it's that flexibility to do a short period back at work, and then build that up in liaison with HR and your line manager and all that kind of thing. And I think one of the things we need to kind of really get our heads around is, how do you do that when these people have generally had very full-on jobs, either as school teachers or pharmacists, doctors, nurses, and that, I think, is what we need to get our heads around. How are we going to do the phased return?
Thank you. Thanks, Leila.
So much. Lord Strasburger.
Thank you, Chair, and good morning to our panel. My question is aimed at the three of you that are suffering from long COVID. And it is, if you were asked to return to work tomorrow, how would you feel about that from a personal point of view and also from a professional point of view? Would you like to go first, Sophie?
Hi. From a personal point of view, I would be absolutely elated to go back to work. I would love nothing more than to be able to go back to a job that I very much enjoy doing and have enjoyed doing for the duration of the time I've been doing it. From a professional standpoint, as it stands, wouldn't actually be safe. I wouldn't be able to carry out safe care with how I am at the moment because of the sheer pain I'm in with my head. There's lots of sort of sensations. I feel like I sort of said, it does feel like someone sort of hit me around the head with a shovel. It also feels like a constant squeezing as well, which does then have a massive impact on how I am able to communicate, how I'm able to concentrate. Obviously in my line of work, I have to be able to think quickly. I need to be able to administer drugs. I need to be able to work autonomously. And I probably would only last, I'd say maybe an hour, if that, before I'd probably have to say, actually, I'm not able to carry out my job as it stands at the moment. There's too many symptoms that I'm experiencing. I'm in too much pain to be able to go back to work. And it's heartbreaking. It really is heartbreaking.
So you seem to be saying that you feel there'd be a risk.
Oh, I would, yeah, 100% I would, yes. And, I pride myself on giving excellent patient care and safe care as well. So I would never put myself, or I would never want to be put into a position where I'm forced to go back when I am not actually physically able, at that point to go back. Then patients would then be put at risk because I wouldn't be able to fulfill my job role properly.
Thank you. And Sue?
Yeah, I can't understand where Sophie is and with these headaches. I mean, I had 2 days of appalling headaches over half term, and how she lives with it is beyond me. Going back to school, I'd love to. My major concerns really is that my mental acuity is not always there. My short-term memory is an awful lot worse than it was. And sometimes I struggle to find the right words to describe things. I've even found myself looking up stuff that Key Stage 3 kids should know, which is depressing. One of my biggest concerns actually is over the school's risk assessments, because the number of symptoms they have on the risk assessment is so limited compared to the symptoms we see on the Zoe app and the long COVID kids. What they're saying that the symptoms in children are different from adult symptoms. And I worry that schools not picking up on kids who may have COVID. and that they're not covering it in the risk assessment. Professionally speaking, I worry about consistency, because teaching is a job where you want to provide a consistent approach for the children. You want them to have some stability with their teachers. They don't always want to have one teacher for a week or 2 weeks and then suddenly they're on supply again. And that is one of my biggest concerns professionally, is that level of consistency that I may not be able to provide.
Okay, thank you, Sue. And Geraint.
Yeah, like Sophie said, again, healthcare professionals, our paramount concern is patient safety. So if anything was to happen to a patient, it would just be absolutely disastrous for the profession and the patient. And again, if I was returned to work tomorrow, declared myself fit for work, who would be liable for a mistake that either myself, God forbid, Sophie, or anyone caused the patient? And then, as well as the professional liability, what about the sort of mental impact then on someone who's potentially been encouraged to work, and then potentially caused an error or harmed the patient? What about the impact that has then on that person? We're looking at the mental health impact then as well. Imagine if you, as an employee, you've encouraged someone to go back into the workplace, and then on day one you've harmed a patient, whether that be slight harm, moderate harm, kill the patient, regardless of level of harm. I think that still professionally would sit with the person and not the employer or the health board or the line manager who has effectively encouraged that person back to work. Again, like we've said about the relapse and remitting thing, like there's been suggestions of multi-organ damage, and are we encouraging people to go back to work without thorough investigations and then putting themselves at risk because they haven't had the investigations? And then what is that impact then long-term on that person? What is the long-term impact then on the workforce? Are they going to be in and out of work? And again, if I was asked to return to work tomorrow, I was working on a COVID ward in a surgical mask. Literally last week, a paper was released to say that actually the highest occupational risk is on wards where there's no aerosol generating procedures. It's COVID-19 positive wards or A&E departments. So if you ask me tomorrow to go back to work, working on a COVID ward with a surgical mask, knowing that regardless of whether it's airborne, whether it's transmitted via other means, there's a higher occupational risk in these departments. And then you're given suggestions, or not you, but the government are giving suggestions that the PPE is adequate when there's actually a lot of evidence now to say otherwise. So in effect, even though people are working in higher levels of virus, essentially, the equipment is there to protect these people, whereas on the other inpatient wards and in the outpatient department, the equipment isn't there. So how can these people be adequately protected? And yeah, that's my concern about returning to work as well. About if I was asked to go back and work on a ward, just put myself at risk again for a second time, or potentially a third time or a fourth time as the weeks progress. Yeah.
So be a risk for you and a risk for your patients, is what you're saying. Well,
a risk for my health, obviously, which you kind of accept as being a healthcare worker, but also professionally, the risk of, if we were to make an error and the impact then on the wider public or the wider profession or even the department or the hospital, it's not just as simple as going back to work and doing your job. That is a healthcare professional, but there's a lot of things to consider.
Yeah, I can see it's just not on, is it? Back to you, Chair.
Thank you so much. Lord Russell.
Yes, I'm going to ask a question about long COVID clinics. You'll have seen the government has belatedly recognised the condition that each of you has and has set up these clinics. Just briefly, have either Sophie, Sue or Geraint, have you actually visited or got an appointment to go to a long COVID clinic? Sophie first.
No, I do not have an appointment to a long COVID clinic because there is none in my area, which is frustrating when you suffer every single day for 11 months of long COVID. And believe me, I have tried. I have a fantastic relationship with my GP who has shown nothing but care and empathy and really does have me at the forefront of her mind when it comes to long COVID. And if there was any sort of service out there, she would be the first person to refer me in our area, and there just simply isn't one in my area. I live in the county of Kent, so that's, you know, it's a large area. So you would think that by now there would be a service for people like myself. I understand that they will be having some sort of a clinic soon, but that's all I've been told is soon. That could be next month, it could be next year, I don't know. And then also you have to then battle with who then gets the first slots, because I'm not sure if it's going to be noted that I say I'm one of the first people in the first wave that have been suffering. There could be someone that's been suffering since November or December, who may very well get an appointment over myself, through just maybe a system error. But, you know, these are the sorts of things that I do think about, and it's frustrating.
Okay. Sue, have you had any contact at all?
Yes, I was quite avid with emailing my MP from the first mention of the long COVID clinics. I'm afraid I didn't really get a terribly useful response. And every time I've been in contact with the GP surgery with repeat prescriptions, etc., and I just kept asking, is there a clinic yet? And the answer was always no. But I looked on the website, and good grief, one had been set up 2 months earlier. Which is a little disappointing. So I made a GP appointment on the phone and was booked in and had my first phone consultation last week. And I've been referred to physiotherapy, psychology, and with the one clinician who is on the clinic at the moment. I live in South Northamptonshire, and there are clinics at Northampton and Kettering, to my knowledge. I don't know when these appointments will materialise, but I am grateful to have got in at some point along this. And I'm hopeful that more clinicians to form a multidisciplinary team rather than just a respiratory clinician will, you know, at some point have time when not treating the very sick and the dying to address our needs too.
Yeah. And Geraint?
At the moment, so I'm not aware of any long COVID clinics in Wales at the moment. So my experience is no access at all to the long COVID clinics in Wales. I was contacted by a local health board to engage me in a post-rehab sort of service clinic, which is mainly for hospitalised patients. But I was told that I wasn't ready for rehab due to my ongoing symptoms. So effectively, I'm not unwell enough to be admitted to hospital. I'm not fit or well enough for rehab. And again, like Sophie said, my GP has been absolutely brilliant, but there's little more they can do than offer just moral support and encouragement of any test results I get, just to share with them really, because there's not much else that they can really offer at this moment. And as much as I agree with the treatment and rehab side of things, is this a plaster over the cracks? We need to understand the mechanisms, the understanding about why I'm having these palpitations, why my stomach goes up and down, why Sophie's having these splitting headaches, why are all these different symptoms happening? Which again, I understand that it's great to be treated, but also we need to know why we're unwell as well. Like I said, I decided to see a private cardiologist due to my symptoms, and just because of a poor experience I had in A&E in the past, I thought it's probably the most suitable option for me really. So my GP had referred me to cardiology in November. I rang them in December and they couldn't provide me a date for when I would be seen, even though my referral was urgent. So as you can imagine, we're in March now and I still haven't heard anything about an urgent cardiology referral from my local health board. So as a patient, this is quite worrying, but also as a healthcare professional, it's also quite worrying that we've got all these patients who have got these urgent referrals and a backlog of referrals from all the other different types of specialities as well, but no one's yet, well, I'm yet to be seen, so I can only talk from personal experience.
Okay, thank you very much. Trish, what on earth is going on? Please explain.
Yeah, so I would say, yes, we need long COVID clinics, but let's just look at the totality here. And I speak as someone who was a GP for more than 30 years. As I understand it, long COVID comes in three broad forms. The first is what we call post-ITU syndrome. It's someone who's been probably on a ventilator, you know, they've had a dreadful, dreadful disease. They've got a chest problem, really. They need to be followed up in the chest clinic by respiratory consultants, respiratory physiotherapists. They need breathing exercises, and they also need to get their strength back because they've probably lost a third of their muscle mass, that kind of thing. The second kind of long COVID is illustrated by the three people we've got on the call. It takes many different forms. It often follows a relatively mild initial illness, but it's not that mild, as they'll tell us. And you get this fatigue, brain fog, possibly a fever, though that's not all that common, possibly a persistent cough. And it's as I say, it's a general multi-system exhaustion, etc., etc. I personally believe that group are mostly slowly getting better, but it's taking a long time. They may need tests to exclude underlying pathology, such as pulmonary embolism, such as the heart question that Geraint is quite rightly concerned about. You know, can I have some heart tests? I've got, you know, chest symptoms, etc., etc. But in general, these people may not need an extensive workup in terms of scanning every bit of their body, etc. And in fact, they may need to be protected from excessive workups if they are getting better. The third type of long COVID is the bit that overlaps with chronic fatigue syndrome and ME. And I think that's a sort of difficult one because some people who've got that actually already had ME type symptoms before they got long COVID, but now it's just made those worse. Now, most of the second and third groups, the reality is they are going to be managed in primary care. They're going to go to their GP, and the rehab that they get is probably going to be in community clinics because we simply don't have the capacity in long COVID clinics to see all those patients. But also, if you are not in the extreme end of long COVID, you don't need it. In fact, you need to be protected from too many investigations, etc., etc. We need to strengthen primary care, and we need to strengthen the referral pathways and the testing. And we've just had a brilliant example of this from Geraint. You know, went to the GP wants a cardiology assessment, but the appointment hasn't come up. So this isn't about setting up a separate system of tests and referrals. It's about strengthening the system that we've got. And those of you who've looked at healthcare systems, I know there's several people on this call who are quite, you know, expert in this. Vertical disease programs often denude the existing healthcare system of its staff, its resources, etc. So I would strongly encourage you to think of long COVID as something that should and will be seen and managed within the main bits of the NHS with specialist long COVID clinics as a component of that. But we also need to think, hang on a minute, why is it taking so long for a GP referral, for a cardiology assessment, you know, to just get the patient seen?
Okay, thank you very much. Back to you, Leila.
Yeah, thank you so much. And Trish, carrying on with you, I mean, the long COVID groups have long called for a registry. And so far the government hasn't been forthcoming. There's been a bit more money for research, which we welcomed, although we argued more is always good. We are concerned that it's not recognised in this country at all as an occupational disease despite the fact that we think it should, in the same way that France and Spain and others have at least recognised it for some groups. But the registry part seems to be, no one seems to be picking that up. How important is such a registry for the work that you do and the work in strengthening that primary care response?
Yeah, I'm not sure about registries. What I do think, it's an absolute no-brainer that you cannot understand any disease until you know its natural history. Now, let's be clear, there's already a lot of ongoing research to monitor and count long COVID. There's the Leicester PHOSP study following people who've been in hospital. And then there's a new study that's recently funded, led by Nish Chaturvedi at UCL. I think Ben Goldacre in Oxford is involved in that. There's the King's symptom study through the Zoe app. So there's lots of different studies to look at the natural history of long COVID. Let's also be clear that the long COVID online groups are fantastic, and I've worked with them and we've published with them, but they don't represent everyone with long COVID. They're very skewed in favour of university educated, fairly young white women. And I'm actually glad that the patients you've got on this call are a little bit more representative of the people who get COVID. We know that COVID disproportionately affects men, minority ethnic groups, and actually also people from less educated backgrounds. That's not that I'm accusing the people on this call of being less educated, but you know what I mean? Now, secondly, the long COVID online groups are made up of people who haven't got better, because I know I was on a support group for breast cancer patients and I left it when I got better. You don't hang around in those groups when you get better. So we've got skewed data at the moment. So we really, really need to follow up cohorts of people who have got long COVID, let's say, get them after 4 weeks, and then see what proportion get better with decent follow-up. Whether we need a registry to do that, I'm not sure. Possibly, but as I say, I'm not an expert on registries. Is that enough from me? I think it is.
Yeah, certainly. Thank you so much. And to round us off in as quick a time as possible, because sadly we have run out of time for this panel, but Brandis Masham.
Do you feel, from personal experience or from the experience of your colleagues, that many living with long COVID will fall through the net where this is existing support or protection? And what must the government do to ensure that these living with long COVID are supported? And a very interesting question would be, have you been offered a vaccine? So could we have the first speaker, Sophie?
Hi. Oh, lots of questions. Okay, the vaccine. Yes, I have been offered the vaccine because I'm a frontline worker. The irony with the vaccine, I can't have it because I have a temperature and I have one every single day. So that's just another issue to this, is that I can't actually probably go back into the clinical workplace until I actually stop having a temperature, because I won't actually be protected by what everyone else will soon be protected by, which is the vaccine. Yes, people will fall through the cracks and are falling through the cracks because our system at the moment is not set up for long COVID. For example, those that do have the sort of remitting sort of factor of their illness. So, for example, I think that there should be a specialised pathway for anyone that has long COVID. Their employers should have almost like an ongoing workforce document for those that are on long COVID, so that if that's identified, as soon as it's identified, then they know automatically, okay, let's check in with that person a little bit more often. When they do need to come back to work, what can we do to flexibility and, you know, how to support them appropriately? We know that they might, for example, their first day might only be 2 hours, whereas like what Trish said, her first day was 4 hours. So what can we do to suit those individualized needs is what needs to happen, and that is not what is happening.
Geraint, thank you very much, Sophie.
So yes, I've had the vaccine. I've had both doses. I had my second dose last Thursday, I think it was, or last Friday. So yeah, obviously really grateful to have that, but there was some contention of whether I would be able to have it with my ongoing symptoms. Thankfully, I'm under a team in Oxford who advised that I do get it, but my levels of antibodies are so high that I'd probably see no response from the vaccine because my levels are so high anyway. But going to the question of about people falling through the cracks, definitely I think so, yeah. Like I said earlier, I'm not unwell enough to be admitted. I'm not well enough for rehab. So are we expecting patients to just sit at home with no investigation or no intervention or no, again, like Sophie said, no pathway to try and get better? There's evidence of multi-organ impact as well. So are we risking patients of organ failure by letting them sit at home with no investigations, and worse, could lead to failure? And again, without large numbers of patients being accepted for research, how are we going to know the true impact, or how are we going to know the effects of COVID on the workforce, on the wider population? And if it's not recorded correctly, also how can the correct support be offered as well? I think the illness needs to be recorded correctly, I think, from employers, because again, if employers are not recording that correctly, how can people be given the support? For example, like my understanding about occupational exposure means a potential or actual exposure to infectious material due to your occupation. So if I was working on a COVID positive ward, which makes my exposure higher than those of the general public, then of course my exposure would be an occupational exposure. For example, my grandfather was a miner. So he, at the time, was, all those years ago, exposed himself to fumes, gas, dust, asbestos. And then as time rolled on, he was diagnosed with interstitial lung disease, which at the time of him beginning to mine, we didn't know, but only years down the line did we know the true impact of people who used to work down the mines. So again, perhaps I think this is why my lived experience of COVID means that I've got a probably skewed view of how correctly this should be reported because of the impact it can have potentially later on in life, or a few years down the line, or in many decades to come. But again, like Trish had said, there's many support groups out there, many of which haven't got healthcare professionals, many of which are encouraging people to take medications that are being obtained from overseas, abroad, illegally. Would they disclose this information to their GP? Probably not. So then, is this safe, really, is my concern. Are we encouraging patients to participate in their own healthcare, which again, as in terms of patient advocating for healthcare, I think there's nothing better than a patient being interested in their own health. But sometimes it can be more damaging when people are essentially trying a cocktail of drugs that are quite experimental, as well as having other comorbidities, as in taking other medications as well, and the impact and the potentially life-changing consequences it can have if things do go wrong as well. But again, there's so many patients out there living with long COVID. Please just access us for support, ask us for advice, ask us to be involved in research, because there's nothing more that, like myself, Sophie, still want to do is get back to a pre-COVID level of health. And there are people out there who I know are going to extremes.
Thank you very much. And Sue?
Yeah, hi. Just picking up on what Graham was saying about the riddle reporting. I feel that, if it was listed as an occupational disease, then it would take so much burden off people, especially in the school profession that support staff as well as teachers. Falling through the net, I have colleagues who are so ill, they are in darkened rooms and on, with threat of dismissal. And it's absolutely heartbreaking. They can't get out of bed, they can't read, they can't watch television, they can't even listen to people talk. And yet they have to fight for their jobs. And a lot of my colleagues are a lot younger than me with small children, and are on stage 2 attendance, etc. and the schools are saying, well, you didn't get it here. So adding it as a occupational disease for many key workers in different professions would be so beneficial, especially for their mental health and obviously well-being. Another group who are disproportionately affected are supply teachers. A supply teacher has no recourse to sick pay. If they can't get up to go to work, there's no money coming in. So there's quite a few people who are falling through the gaps through no fault of their own. And that's just a real worry. And I think the other thing, sorry, please butt in.
No, sorry, no, I was just going to reinforce your point about saying about where people actually acquire the infection. Like, for example, I was told that I could have got the infection from a supermarket by my seniors, even though I was working on COVID positive wards. So again, yeah, I fully understand that there is a complete disconnect about people acknowledging where the infection was even acquired, even working in the settings themselves. So yeah, I completely sympathise with that point. Yeah, completely. Sorry.
No, it's fine. We did a survey on the Teachers with COVID group, and only one person out of the 50 respondents, no, 70 respondents, said they definitely didn't get it at the school. You know, and everybody else, it was roughly a 50-50 split, most likely, quite likely. Because we know where we'd been. You know, if we hadn't been to a supermarket in the preceding week, if all we'd done was go to school and maybe walk our dogs, you know, it's very, very probable. But it's that burden of proof. And the riddle guidance does say most likely, but schools are not taking that on board to some extent. I mean, I'm on half pay now, which as a single person is going to be quite difficult. But there are others who are much worse off. You know, I can stand and fight my corner, but what do you know, somebody's in bed and they can't move or bear to be anywhere. How are they going to fight? And the union's advice is to resign rather than be dismissed. I mean, how does that equate with anything? Sorry, it's a very emotive subject for me, this.
Yeah, thank you, Sue. And on that note, we do need to move on now, I'm afraid, Baroness Mashin. I'm so sorry, I'm going to have to cut the question.
Can I just say they've been brilliant?
They have been absolutely brilliant.
Very much.
No, thank you so much, all of you. We are because we are going to now move on to talk to said unions, and let's ask that question that you've posed, Sue. I think it's really important. So Sue and Sophie and Geraint, an enormous thank you to all of you.
Thank you.
Sparing the time, especially given your conditions and everything else we're going through at the moment. We don't take your time lightly at all. Thank you so much. You are very, very welcome to stay and listen to the second half. Trish stays with us for the second half, and it's a delight to also welcome from NASUIT Teachers Union, Wayne Bates. Wayne is a national negotiating official for NASUIT, the Teachers Union. His role includes negotiating with some of the largest multi-academy trusts and the governments of Jersey, Guernsey and the Isle of Man. He has also national oversight for health and safety, so very well placed to discuss some of these things. He also taught physics for 13 years in a large urban secondary school. So from one physics teacher to another, hello. Thank you for being with us. And from the British Medical Association, we have Dr. David Strain. He is a senior clinical lecturer at the University of Exeter Medical School, an honorary consultant in medicine for older adults, head of the academic department for healthcare for old adults, and co-chair of the BMA's Medical Academic Staff Committee. He's played a leading role in the BMA's COVID response and is researching long COVID as part of his role as a senior clinical lecturer at the University of Exeter Medical School. And he also told me in the chat that you've also part of the Long COVID Assessment Service in South West, so is also very much involved on that front line of things too. So thank you both for joining us, really very much appreciated. And I suppose the first thing I wanted to ask was, in terms of the APPG has been calling for the government to launch a compensation scheme for frontline workers, for people like Sue who are now on diminished pay. We've also heard from other frontline workers who have lost their jobs completely. David, can you explain the reasons why the BMA supports this and what the implication of such a scheme would be for your members? And to the others, why is it that those with long COVID should be financially supported? David.
Thank you, and thank you for the opportunity to talk here. So from the British Medical Associations, we've seen lots of our members, similarly members from the nurses, from the therapists, right across the hospital have been exposed to COVID as part of their day-to-day duties. Very early on in the pandemic, as Trish has already highlighted, that we identified those at the highest risk of developing ITU and ending up dying of COVID, but early on we didn't know about this instance of long COVID. As a result, we have been putting those who got a lower risk of dying very much in the front line, and it turns out that they are being far more affected by the long COVID. We are seeing younger, fitter, healthier people whose lives have been ruined, and I've just been listening to Sue, Grant and Sophie's stories. It reflects a lot of what I'm seeing in clinical practice as part of the long COVID clinical service. And we are seeing healthcare workers being disproportionately affected. This is not just doctors, this is all healthcare workers. In our service, 10% of our referrals are healthcare workers who we are confident have contracted this as part of the day job, trying to look after these patients. As such, we feel that they are appropriately supported. And let's say this is, when we're talking about a compensation scheme, we are talking about for people like Sue who are not earning their money, who are not earning their salary as a result of the job that they have done looking after people with long COVID. This is particularly pertinent for those who have been treated earlier on in the pandemic when personal protective equipment was not available. When it was available, it was not fit for purpose. I, like 5 members of my team, caught long COVID using the WHO recommended PPE, caring for patients with COVID at the time. And this has been a point that we have many healthcare workers and other frontline workers that have been affected by doing our day-to-day duties. They therefore need to be supported in order that they can have their phased return. And like Trish says, many are returning back to work. This is not a lot, hopefully, where this is not going to be a in perpetuity effect, but until they get that phased return rather, we don't feel people should be balancing the half pay that Sue is experiencing at the moment on top of all of their other stresses, while they are desperately trying to get back to the job and the work that they love doing.
Thank you very much. Wayne.
I think there's a few aspects to this. I think primarily one of the issues is, and Sue really summed it up really well in the way she talked earlier, particularly around employers refusing to accept that there is any possibility that the virus was contracted in school. We're seeing that all the time. Now in the teacher's contract, there's a document called the Burgundy Book. And in the Burgundy Book, it does contain enhanced sick pay for teachers who contract infectious diseases whilst at school. Of course, going back to what I just said, schools are denying that there's any possibility that the virus was contracted in school. So therefore, teachers who are suffering with long COVID, they can't access that enhanced sick pay through the Burgundy Book. And we're seeing now staff coming through, teachers coming through, members coming through, where they're at risk of dismissal because they've been off for so long. They're going down onto half pay or even approaching zero pay. And there is also a huge variety in employers. Some employers are being very sympathetic. They are, extending sick pay provisions. There are, of course, employers at the other end of that spectrum that are seeing or treating this very, very punitively and are seeking to dismiss our members as fast as possible to try and get them out. They're seeing them as a hindrance, a cost to their business that they need to remove as fast as possible. And having some kind of compensation scheme, of course, it doesn't, resolve the issue that response is inappropriate, to say the absolute least, but it would at least acknowledge that teachers were at the forefront, are at the forefront. David mentioned PPE. Of course, there is no PPE for teachers. Teachers went back yesterday, and I'm not sure there's many other workplaces where teachers will be, where the employees will be expected to be in a room with 30 other people for hours on end with virtually no protection at all. I know the government has introduced a recommendation for face masks for pupils, but they pretty much said that schools can't enforce that. So there is still that ongoing risk of infection for teachers. I'd say it's possibly greater than other workplaces, perhaps with the exception of healthcare workers, obviously. But certainly as the economy as a whole, I'd say teachers are more at risk. And teachers are falling ill, but they haven't got the compensatory schemes. They haven't got the fallback necessary for when or if they contract the disease and unfortunately then go on to get long COVID.
So is it the change in the riddle guidance that is the key thing here, Wayne, for you? Or is it broader than that?
I think it's broader than that. Changing the riddle guidance would help, but I think generally the number of riddle reports has been extremely low across the whole economy, not just in teachers. So, I mean, there's kind of a bigger question there about the whole kind of response from the health and safety executive as well. Of course, right from the start, they've seen this as a public health issue and not as a workplace illness and not as an occupational illness. And that in itself has been a major issue. And also the fact that the HSE effectively downgraded it and didn't regard it as the most serious type of problem that people are facing.
Thank you very much. Trish, anything to add on this one?
Yeah, I'm not an expert on worker compensation or that kind of thing. I would speak as an experienced GP who signed a lot of sick notes in my time. Perhaps that's the way you should interpret this. My two penneth is that we should be thinking of this as disability rather than sickness. And the reason why I say that is that the definition of a disability is that you've got a physical or mental impairment, and that impairment has a substantial and long-term adverse effect on your ability to carry out normal day-to-day activities. So I've just read that from the Equality Act 2010, which was derived from the UN Disability Convention. Now, that includes long-term illnesses such as cancer or multiple sclerosis. And I think that rather than try and create some kind of unique set of provisions for people with long COVID, what we need to do is ensure that people with long COVID are properly treated in accordance with the broader rights of people with disabilities, not least because people with disabilities already have protection in law in most countries, certainly in this country, and that protection can be accessed immediately. Now, it is true that in practice, benefits for people with disabilities can be limited, they can be hard to access, but at least then there's a sort of known problem and a known set of actions that can be built on. Now, I haven't heard many people with long COVID and long COVID support groups talk about disability, and I absolutely get that being ill is less stigmatizing than being disabled, but the legal and financial protections come through the route of disability. Now, then the question is, well, hang on a minute, how can we assess whether a person with long COVID actually meets the criteria of having a physical or mental impairment, which classifies them as having a disability? And I think the ones we've heard today, you know, it's not very hard to work out that they can't do their jobs. They're not inventing this. They're not making it up. So I think it would be pretty straightforward for GPs, occupational health physicians, etc., to go through that route. And actually, the World Health Organization has got a number of questions now. They've got what they call a standard long COVID data set. I've got it in front of me. A lot of it is about function. Could you walk a kilometre? Could you concentrate on doing something for 10 minutes? But also, could you maintain a friendship? Could you do your day-to-day work? I mean, these are the questions which are now being systematically collected by the WHO. So that is my suggestion. It doesn't get us any further with this business of worker compensation. What I'm worried about is we're going to end up with a two-tier system, which is people who can prove they caught it at work are going to get one set of benefits, and people who can't prove it but might well have caught it at work are not going to be able to access those benefits. And I think we need to get our heads around that little tricky issue.
Thank you so much. Lord Russell?
Trish, just to follow up on that, you co-authored the WHO briefing paper on long COVID. Did you look at the ways in which other countries are responding to the questions we're debating at the moment? The research our team did beforehand, I think, shows that France, Italy, Spain, Germany, Belgium, and Denmark have all in various ways tried to put in compensation schemes for people with long COVID. Can you inform us on your knowledges of what's going on and the direction
you know way more than I do about this. Although I was on the WHO report as a co-author, my input was relatively minor, and it was around the kind of clinical lived experience stuff, not around this bit. So I'm not the relevant person to ask. I did ping an email to one of the other authors over the weekend, but they were so busy they haven't yet got back to me. If you want me to take an action point and ask about that, I can do.
That'd be really helpful, Trish. Yeah, we'd love their input if that were possible. Thank you so much. Sorry.
Just perhaps, David, with your BMA hat on, are you in communication with any other national BMA type organisations and have any view on what's going on in their countries?
Actually, I'm quite closely in touch with the Commonwealth Medical Association, which brings in members from around the world. There are many countries that haven't even started to look at this. Actually, one of the countries that surprised me about how quickly they have responded to this is India. And in India, within the healthcare worker system, they are actually putting support in place right across the board for healthcare workers. Now, at the moment, that is exclusively for the healthcare workers within certain regions of the country. It is not extending to non-healthcare workers as yet, but I'm actually this evening going into a call with Brij Makar in New Delhi, who is talking about developing this as an occupational disease there. And they've got the most advanced of the systems that I'm aware of. I have to admit there are many countries that aren't even as far along as we are in supporting people who've caught this occupationally. So just by virtue of this gathering, we are a long way ahead of some other places.
Thank you very much. Well, if you pick up anything that would be of interest to our research team this evening from India, please can you forward it to the team?
Wayne, is there any country that recognises it for teachers that we know of?
Not that I'm aware of, no.
Thank you. The other thing I wanted to ask, and this is perhaps for Trish, but feel free, Wayne and David, to chip in. We've heard a lot of ministers suggest that we're just going to end up living with COVID a bit like flu, and that it's going to be something that sort of hangs around and we're going to have regular jabs. And I just wanted to ask, while we had Trish here, do you feel that that comparison is a helpful one or not?
Me, no. I think we've got into an awful lot of hot water by assuming this illness behaves like flu, and it clearly doesn't. I could expand on that, but we're already short of time. I don't think that's very helpful.
Thank you. Do expand just a little bit more, because interestingly, the narrative that it is like flu seems to be going around like wildfire in Whitehall at the moment.
Oh, right. Okay. Well,
can you explain why?
Yeah, dear Whitehall, show me someone with long flu. I've never seen anyone with long flu. And my goodness, as a GP, I've treated an awful lot of people with flu. Look, you get flu, you get wiped out, you either die of pneumonia or you get better. That's a little bit of a sweeping statement, but flu does not give you this protracted, post syndrome that we've heard about. It just doesn't do that. I mean, all right, someone will come up with one kind of rare case, 1 in a million, and yes, I'm sure that's the case. But this is completely different. Clinically, it's different from flu.
Thank you. That's very helpful. Wayne, did you want to come in?
Yes, I think Tricia has hit the nail on the head there, actually. I mean, before this, I've asked some of the multi-academy trusts that I deal with, what kind of figures are they looking at for the numbers of people that have had a confirmed case or been of COVID and are off on long-term sick, which is defined as more than 4 weeks. Now, I've only asked that recently, so I've had much response, but out of the couple that have responded, the first have reported that 5% of the staff that have reported a positive case are still off on long-term sick. And clearly, if that is replicated, and it's, you should, granted, we shouldn't draw firm conclusions from a single data point, but if that is replicated across the system, 5% of teachers and other education staff off on long-term sickness because of COVID is going to put an incredible strain on the education system. It'll also put an incredible strain on the people themselves, because they will come under pressure to return to work or to be dismissed as schools will try to manage the situation.
Thanks. David, do we have any numbers from the BMA on this?
Numbers of people off. We know at the moment, well, I mean, the simple estimate is it's about 10% of the population who've had long COVID, who've got COVID, have been left with some residual symptoms at 12 weeks. And that's from the Office of National Statistics. Of those, not all of them are off work. So about half of those who are with residual symptoms are in a position like Sue, Sophie and Grant, that they're unable to do their job in a normal manner at the moment. We're getting more and more reports of people who are part of a phased return to work, and therefore they're not able to do their jobs to the maximum of their ability. And I mean, that's affecting people in different ways, because it's also affecting the people that are left behind, that are then having to pick up the extra work. We went into this pandemic with shortage of healthcare workers, about 80,000 staff short compared to what we need. And we know the government was attempting to address this, but then taking more people off because of long COVID. And I think Tricia just put in the sidebar that the Royal College of Physicians have estimated that there are nearly twice as many people off with long COVID than have been off with COVID or quarantine as a result of it. That's putting additional stress on the service both ways. In primary care, that's an even bigger problem, because remember, in primary care that the GPs are effectively independent contractors. And there's huge issues then about how is that going to be offered. I have to say, I've been very fortunate. I'm part of phased return and I'm still not back to work normally, but I have been incredibly well supported by my line manager. And it's helped by the fact that I'm also clinical lead for COVID. So I've had a bit of an input into the way people are being served. But in primary care, we've got many reports of GP partners who can no longer support the staff within the budget that they've got, or people just effectively losing their job and being unable to pay their mortgage from a fixed contract position. They are the sorts of issues that we are facing across the board. And to say that this is just like flu is just absolutely ridiculous. As Trish says, you don't get long flu, not since 1918 was the last case. And yes, there will be a group of very elderly, very vulnerable people who will have COVID on their death certificate instead of flu. But it's also the carers, the people working for them in the community and in the hospitals, who are going to be adversely affected long term. We cannot start making plans for a 5% of the workforce off at any one time without looking seriously at the impact that's going to have on the economy as well as the healthcare system.
Thank you, that was very helpful. Baroness Masham.
In terms of returning to work, what are the key concerns of your members who have had COVID, and more specifically, those now living with long COVID? And surely safety for all should be paramount. Could we have David, please?
Yep, that's a brilliant question, and the different elements we have to take in turn. So the first is making sure the safety of that person who's suffering this condition. Sue actually highlighted the very easy the tidiness that you get from this. We have to have longer rest breaks in place. We have to have the support that if somebody is having a bad day, they can be taken away from those frontline duties, because we know that bringing people back to work within an energy envelope basically allows them to do what they love doing, continue to provide a service, and make sure that they can continue doing it longer term. And the idea would be eventually they will get back to where they need to be. But it's about making sure that they have the support and the team around them so that they're not putting either themselves at risk or the people that they're caring for, whether that be patients in the case of healthcare workers, whether it be pupils in the case of educators, or many of the other key workers. We need to be protecting not just the individual with long COVID, but the people that that's in their care.
Thank you very much. And Wayne?
Yes, I think I'd agree with what Dr. Strain has said. I caught Dr. Strain's submission to the Horizon programme recently, where he said that one of the key things that you're seeing is that people who essentially don't rest enough while they've got symptomatic disease then go on to develop long COVID. And I hope I've got that right. I'm sure he'll correct me if I haven't. But one of the features of teachers is, and I experienced this when I was in the classroom, is I saw many colleagues coming back to work before they were fit to do so. And I'm not talking COVID now, obviously, I'm talking about other illnesses. Teachers want to get back into the classroom. They feel a duty to pupils. They feel a guilt to their other colleagues who are in the classroom covering, for their absence. And there is a real fear from the union's point of view that many teachers will push themselves far too quickly to get back after a COVID illness, and that will result in higher levels of long COVID going forwards. We are also concerned that schools have been closed since January. There may be numbers of people who are suffering from long COVID who have been able to cope with working from home, from delivering remote learning, but when they try to go back into the classroom, then we'll start to see essentially a flare up in the numbers of people off work with long COVID in schools. And I think part of it, one of the parts that will be absolutely key when people return will be a risk assessment approach to make sure that they are doing what they are capable of without putting themselves at risk. And I mean, we talk about just within the workplace, but I don't think we ought to lose sight as well of, if somebody goes to work and exhausts themselves at work and then has to travel home, and invariably that's probably going to mean driving home, does that actually put them at risk and put others at risk while they're traveling back home? So that's a kind of another dimension to the issue as well, I think.
And would that include teaching assistants? And do you think they should all be vaccinated?
Yes, I mean, the NASUWT only covers teachers in membership. But clearly all education staff working in schools and in classrooms are having the same experience. And we had a very prominent campaign to try and get teachers and all education staff vaccinated. And we were very disappointed that hasn't occurred. And going back to what I said earlier, teachers are now back at school ahead of the rest, or a lot of the other parts of the economy that haven't opened up yet. There's very limited safeguards in schools and in classrooms, and vaccination of staff seemed a very obvious way to give some additional protection that teachers and other education staff now have not got.
Thank you very much.
Well, thank you both. Thank you both very much.
Barbara Keeley.
Thank you, Leila. Thanks, Chair. I'd like to ask the panel, I think we touched on this, but I'd just like to ask you about what you feel the numbers are in terms of people living with long COVID who are falling through the net of existing support or protection. I think we've heard of a few examples of that. That might be, as Wayne has just said, people coming back to work before they're well enough because, maybe they feel pressured by HR or people not being very supportive of them. Any sort of feel for the numbers of people who are living with long COVID but are not, not getting the support and protection they need?
To answer that, the first thing is we really don't know how many people have got long COVID. The SNOMED code, so the GP coding for long COVID, only came into existence on the 17th of January, and I've been going through some of the databases looking to see how good the coding is. The problem is the coding is then based on GPs actually, firstly, knowing it's there, then knowing that there's something to do about it. And although we've got these assessment services at the moment, as Trish has already highlighted, we still don't really know what to do with a big chunk of the patients who've got long COVID. I mean, I'm going from here into an NDT talking with some of these patients. The ones, as Trish highlights, are very clear respiratory or very clear cardiac, they're easy. But it's the ones who've got this chronic fatigue-like illness, or the ones like Sue's describing that's just having this relapsing, remitting condition, we don't know what to do with. And I know that's not answering the question directly, but in a way it is, because doctors are not very good at analysing, at looking at these numbers if we don't have anything to do with it. We don't look for conditions that we can't treat. And at the moment, it's important that the research that Nish is doing, that Paul is doing at Imperial, that I'm involved in, and some of the genetic stuff that is taking place, it's important that we get these up and running as soon as possible, so we know what's causing it, how the different presentations are of it, so we can do something about it. And only then will we really get a grasp on how many people there are out there who are going to need these different services.
Okay, Wayne, do you want to add to that?
Yes, I think I'd agree with everything Dr. Strain has said. With regards to the data, we have really struggled to get high quality data from employers just around the numbers of cases. We've issued freedom of information requests to local authorities. The majority of those replied saying that they're not collecting the data on cases. And if they're not collecting the data on cases, they're certainly not going to be collecting the data on long COVID. And we've equally struggled to get good data from the Department for Education as well. So I think that's kind of symptomatic of a bigger issue, that there seems to be an unwillingness, perhaps that's going too far, to collect the data that we need to address the issues properly.
Thank you. Thanks. And Tricia, we've got a couple of messages in the chat. Sue says that, going back to what Wayne was saying, colleagues attempting phased return, that they're spending their home hours sleeping and in bed. So, it may look like they're on a phased return, but not if they're having to sleep all the time, that they're not working. Tricia, do you want to add, because you've said SNOMED codes should help going forward?
Yeah. No, that was just adding on to SNOMED codes. We can't rely on them at the moment, but there is a data quality effort, huge effort to get this whole thing properly coded and followed up in primary care. What I wanted to point out was we've looked at a lot of doctors, nurses, physios with long COVID. We haven't looked at teachers actually, because none came our way. But there's two things they worry about in terms of what is it about their long COVID that makes them worried about going back to work. And the first is, the whole thing is about the brain fog. I mean, yes, they talk about fatigue, but they talk more about the brain fog. And that affects them in a couple of different ways. I spoke to a pediatrician who said, I'm worried about going back to work because one of the things we have to do as pediatricians is calculate the dose of a drug that we might be giving intravenously to a tiny baby. And you have to multiply milligrams by kilograms and all that kind of thing. And of course you use a calculator and you check it, but you have to be on the ball for that. So the idea that you're responsible for making mental calculations that are really life dependent if you get them wrong. So that's one of the things. But the other thing that they talked about, and one interviewee used a wonderful metaphor of, you know, when you've got your computer with lots of different windows open, as professionals, whether it's teachers or healthcare professionals or whatever, you have a lot of windows open in your brain. You're managing a lot of different things. You know, even a teacher teaching the class is also worrying about kids' behavior. They're worrying about maybe there's a child who's a child protection case, you know, all those kind of things. You have to keep all those plates spinning in your head, and they can't do that. When you've got brain fog, you can only focus on one particular thing. And I've got a member of my staff with long COVID at the moment, and he said, I can't do any Zoom meetings. I can't do anything that involves a team effort when you have to keep lots of different channels open. So I said to him, what can you do? And he said, well, I just want to work on one paper that I'm writing, and I want to be able to just do as many hours as I can and then go to bed when I'm tired. And I said, okay, that's fine. The problem with professional jobs is that we do need a lot of mental windows open often because you're processing multiple channels of information. So I think that is one of the reasons why professional people in particular are finding it hard to get back to work.
Okay, thank you. And it certainly, Geraint, it underlines what Geraint told us earlier about the calculation and him, you know, not wanting to kill a patient by through his brain fog affecting that. So thank you. Thank you, Chair.
Thank you so much. So David, there you just said just waiting ethics review. What are you referring to there in the chat? Oh, I think you're on mute.
Yeah, that happened. Had to happen once. Sorry, Sue just sent me a message about the study that I was talking about with ethics and mitochondria and genetics, and she sent me a private, and unfortunately I put it to the whole panelist. Apologies. Oh, that's just to say one of these studies that we're going to be doing looking at mechanisms is hopefully going to be starting by Easter.
Thank you.
My apologies.
No, not at all. It's always very useful stuff. And so just for our very final question to Lord Strasburger.
Thank you, Chair. What are the key concerns that the government needs to address with respect to long COVID now that people are starting to go back to work? Trish, would you like to go first? You're muted, Trish.
Sorry, you went blank there. Can you just repeat the question?
Surely. What are the key concerns that the government needs to address with respect to long COVID now that people are starting to go back to work?
Yeah, I think one of the issues is that employers at the moment are bearing quite a heavy burden when, I mean, you know, we've heard people describe dreadful inability to get back to work, but of course as an employer you've got to deliver on things. So for example, I'm contracted actually by your government to do some work, but some of my staff have got long COVID. Now you're not going to be very happy if I say, well, I couldn't do the work but you still pay me for it. So I think there's an issue of who is going to pick up the tab for people who are unable to work. Perhaps, you know, we've got, you know, obviously the employer pays for the first 6 months, but what happens after that? Apart from that, I think the government's doing pretty well in terms of supporting more research, improving long COVID clinics. You know, I'm on Lord Bethel's task force, but I suppose the other thing I would say, and I've said this earlier, but I'm going to bang the drum again, is strengthen primary care, because the general practice system, the community physiotherapy support system is going to be what actually does a lot of the heavy lifting with long COVID. And I think if you can channel some funding into that, you're going to get fewer people needing to go to the specialist services. But also, guess what? We GPs are pretty good at getting people back to work. That's what we've been doing for years. After hysterectomies, after pneumonias, after all sorts of, you know, accidents, we actually do that bit about negotiating with people about how long the certificate should be given for and all that kind of thing. So bring the GPs in is my suggestion.
Thank you, David.
I mean, I don't want to, in the interest of time, I'm not going to repeat everything Trish said, but I would put one extra caveat in, that we need more academic GPs. I mean, Trish is an outstanding example of how you can blend the day-to-day running of practice with the understanding and integration of this new information. This is a new disease, and although there are links to other conditions around, we do need yet more research, and the projects have all been announced are all very much focused on the observational aspects of trying to figure out what are the underlying causes, but we're going to need studies going into the treatments of this going forward. We're also going to need to try and find out what extent long COVID is doing. I mean, we're seeing it a lot in the people who are back to work. There are many people who are spending their entire working life at the moment sat behind screens. They are probably completely unaware that they're going to be fatigued if they try and do a full day of walking around. They may not be aware of the fact that the brain fog is even there if they have a role that enables them to focus on one thing, that as they start to integrate into society again, they will see the fact that this is a much bigger problem. And then there's going to have to be specific support in order to get the key workers, to get the occupational health services back, to get those key workers doing what they need to do. And again, I want to just come back to the comment Trish said. To regard this as just another flu is utter nonsense. This is going to have an impact if we don't get on top of COVID itself. Then long COVID is going to continue to have an impact both on the key workers, those who cannot go through a COVID secure type working environment, and then the wider economy if we don't get on top of it soon.
Thank you, David. And Wayne?
Yes, thanks. I mean, I think I've already spoken about our concerns that the return to schools is going to cause a greater number of infections in school staff, which is then going to have a knock on to more long COVID cases. If we look at what's happened recently in Guernsey and the Isle of Man, they both had quite big outbreaks, and those outbreaks have been, schools have been right at the centre of those outbreaks. I think a third of cases in Guernsey were directly linked to schools. The current outbreak in the Isle of Man, just before the weekend, half of all cases were directly linked to schools. So we have got those concerns that we're going to see more infections in education staff, which will lead to more cases of long COVID. One thing that we haven't touched on today is around ill health retirements. Clearly, there's going to be some teachers who are unable to return to work. There are going to be some that are dismissed, but the rules around ill health retirements are exceedingly strict. And basically, in a nutshell, you can only be awarded ill health retirements if you can show that you will never be able or be fit enough to teach again. And certainly in the case of long COVID, I think it's going to be very, very difficult to make that determination. Therefore, potentially we're going to have a lot of people who are unable to return to school, but are unable equally to claim ill health retirement.
I think that's the story of long COVID, isn't it? Lots of people falling between two stools. Mm-hmm. Back to you, Chair.
Thank you so much. Well, guys, I'm always sorry to say that we run out of time, because every time we do one of these panels, we feel we could keep you for days to download the information. But thank you so much, all of you, especially Trish, for suffering us for an hour and a half. But everyone who has been so generous with their time and knowledge. If anything comes up, it sounds like there's quite a few things happening even over the next few days that you'd like to keep us abreast of. We very much welcome an ongoing dialogue with all of you or anyone else watching who wants to send in more information. We certainly won't be stopping looking at long COVID. It's going to be, as I think David said, something that we're going to have to deal with as a country. And so far, we haven't seen as yet enough response from government taking this seriously to the extent that we'd wish at this point. So thank you again to you all, and thank you to our previous panel. Hope you have a wonderful day. It's sunny here in Oxford, and I hope you stay safe. Thank you very much, everybody. Bye.
Thank you.